Thank you everyone for joining us today. My name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. We've got a great program lined up for you today about using remote patient monitoring. And before I introduce our speakers, just a couple of housekeeping rules. We are recording today's session. It will be posted on our website with the slides and also on our YouTube page. We will be doing a survey at the end, so we look forward to your feedback so that we can share that with our presenters. Everyone is in listen-only mode. If you would like to ask a question, please use the Q&A function. We will hold questions until the end, but go ahead and type them in as you think of them. If you have any technical issues, please use the chat function, as we will be monitoring that as well. With no further introductions or announcements, I'm going to go ahead and introduce the four panelists that we're going to have today. Catherine Gray is Senior Manager of Technology Services at McKesson Medical and Surgical. Rebecca Russell is Director of Program Management at Remetric Health. And Wanda Charnock is the Senior Revenue Account Cycle Manager at Coronis Health. And we also have Todd Blakeney from Coronis Health. So I'm going to turn things over to you guys, and please take it away.
So good morning, everybody, and thank you so much for joining us today and helping us to bring the news of remote patient monitoring and what it can do for your practices. So as I try to move to the next slide here, there we go. All righty, so what we're going to talk about today again is remote patient monitoring. We hope to be able to give you sort of the rundown on how you can do this for your practices, sort of establishing the workflow, making sure you understand the right patients to include and how to select the right patients for the program, and then navigating the waters of reimbursement within your organization as well. I will say at the outset, we're going to be talking some about reimbursement and financials associated with this. These are just examples. This isn't our recommendations necessarily for your specific practice. So please consult your advisors and understand for your organization what this means to you. So want to just introduce a little bit further who we have on the call today. So my name is Catherine Gray. I'm with McKesson Medical Surgical. I lead our virtual care offering, so understanding what our customers are doing across the care continuum, what they need to be successful in the virtual care space, and making sure that we have those solutions and products to help them there. I'm joined today by Rebecca Russell. She's the Director of Program Management for Remetric Health. They're an FDA registered, fully integrated remote patient monitoring service company. For decades now, they've been helping physician groups and hospitals and home health agencies really improve outcomes through remote patient monitoring. Rebecca's been with them for quite some time now. She's been working with them since 2010. She began her career with them teaching lung transplant patients how to use the first ever personal spirometer. And today she works with a variety of companies across the country and has a wealth of knowledge surrounding helping them onboard and implement remote patient monitoring programs. Also joining us today is Wanda Charnock. She's the Senior Revenue Cycle Accounts Manager for Coronis Health. Coronis is a revenue cycle management services company. They're not a software, they're a service, and they do billing, coding, payment posting, AR cleanup, denials, you name it. Wanda's been in the business for 30 years, helping healthcare industry, and brings extensive experience working with professionals and hospitals with all of those areas, including accounting, auditing, and consulting services. So I think we have some real wealth of information for you today. So getting started, I want to sort of set the stage of what's really driving remote patient monitoring. We're hearing a lot about that today. And even prior to COVID, the environment was really ripe for remote patient monitoring. We have rising patients with chronic conditions. We have a strong need to reduce the overall cost of care. And then we also have patient demand for convenience with a reduction in providers, but a increased number of patients. So wait times to get in for appointments were, very challenging. So that environment really created an opportunity for remote patient monitoring. But then we had COVID arrive on the scene, and with COVID, we've really seen that be escalated, right? So with not just the safety issues, people not leaving their homes. And so that really has spurred that, as well as some of the reimbursement that's come online for remote patient monitoring in the last couple of years, and grants for remote patient monitoring as well. There have been a number of studies, sort of what's happening in the marketplace. We've seen the study by Spyglass Consulting, which was done in November of 2019, found that 88% of providers were considering some form of remote patient monitoring. And in addition to that, our survey of McKesson customers in August of last year, so 2020, found that 40% of our customers that were expanding telehealth were also adding remote patient monitoring. And overall, we at McKesson Medical Surgical have seen a real increase in requests for customers to talk with us about what options are for remote patient monitoring and how they can implement these programs, and really helping them be successful in this space. And so we're seeing community health centers and physician offices and health systems and home health and even skilled nursing facilities and durable medical equipment or home medical equipment providers also looking to see how they might implement these solutions to help them with their patient population. And then a survey by Sony in June of last year showed a real comfort level by patients with remote patient monitoring, with 90% of patients believed it could help them. And more than half of patients would switch doctors if they felt another offered remote patient monitoring. So patients certainly are very open to this, and providers are really starting to look toward remote patient monitoring to sort of help them drive better outcomes. And there is a lot of efficacy around outcomes associated with remote patient monitoring. But I am going to turn it over to Rebecca to talk a little bit more about that. Rebecca?
Okay, great. Thank you so much, Catherine, and thank you all for allowing us to provide this information today. So my part of the webinar, I'll tell you a little bit about the why remote patient monitoring, as well as the how. So next slide, please. Okay, great. So the first thing we'll talk about is the clinical impact with remote patient monitoring. And I think it's important to note that this isn't something that's new. I know it's being talked about so much more these days, but just to give you an example outside of what you're seeing on the slide is the VA, the Veterans Association, back in 2008 conducted a study with 17,000 patients using remote patient monitoring, and they got about a 20 to 22% reduction in overall readmissions. But as you know, technology is advancing very rapidly these days. And so the studies that I'm sharing with you here are some of the newer studies that are out there and information, but there's a whole host of information and studies and data that's been out there regarding the utilization of remote patient monitoring and how that impacts patients as well as the providers. So the first one we'll start with is Banner Health. This is a really substantial study. They targeted the study at their most complex patients. So these are patients who had 5 or more chronic diseases. They reduced readmissions by 75%, hospital admissions by 50%, and the overall cost of care by 34%. So really, really superior results in this particular study. Partners Healthcare is another one. They used remote patient monitoring on 1,256 patients that had cardiac disease. They cut their readmissions down by 51% and saved $10.3 million. Centera Health is another one. They went from a readmission rate at 15% all the way down to 2% with remote patient monitoring. UPMC is right here in Pennsylvania, and they say that their patients on their RPM program are 76% less likely to be readmitted to the hospital. They have a 90% compliance rate as well as a 90% satisfaction rate. So again, this is just some of the data that's out there, but I think for the most part, people do recognize that, you know, the clinical efficacy of the program is there. Next slide, please. Okay, thank you. And I think I saw a comment pop up. We might be saving questions till after, but it was around primary care. And so I definitely want to address that as well. And in fact, this slide does. But there's a number of different segments across the healthcare industry that are using remote patient monitoring. Everybody's using it to reduce readmissions, improve overall quality of care for patients. I'll state that, but there are some differences among the segments. So remote patient monitoring helps high-risk patients by monitoring symptoms, vital signs, sometimes medication adherence closely, and then providers are notified if intervention is needed. So that's sort of like the definition of it, but I want to give you an example. And this is a real life example. A dear friend of mine, he used to take his mom to the hairdresser. She was older, she had had a stroke, she has heart disease. And I used to take her to the hairdresser once a month. And one day they were walking into the hairdressing salon and she was like really lagging behind quite a bit. And my friend says to his mom, he says, "Mom, you know, what's going on? You seem to be out of breath." And she just makes a comment like, "Honey, I'm getting old, you know, what can you do?" And then later on they're home and she kind of sits back up on the couch and puts her feet up. And he notices that her feet are really swollen. And he says, "Mom, your feet are so swollen." And she goes, "I know, what do you think? That's why I've got them up in the air. I'm doing the right thing." And he goes, "Mom, you got to tell your doctor about this." And she says, "I will, I'm going to. I have an appointment with him in 2 weeks." And so the whole point of remote patient monitoring is if she was on this program, her healthcare providers would have been alerted if the reason why her feet are swollen is because she's put on 3 pounds of fluid overnight, or if she's short of breath because her blood oxygen saturation is starting to dip. That's something that they would have received a notification about. So that is a real life example of really how remote patient monitoring is used kind of across the segments. But in the health systems, we're obviously seeing, as from the studies that we already just looked at, a significant reduction in readmissions, improve patient outcomes. A lot of times in the hospital setting, they'll use it in their care coordination or the transition of care programs. They're using it to improve their quality metrics, their performance measures. And then in the home health world, we're seeing it a lot in the home health space to, first of all, supplement their in-person visits and really optimize those in-person visits when they are with the patients, because they can see those patients' vitals on a day-to-day basis. They can see their trends. They know the patients that are most crucial that they get out to and see on any particular day, so they can really kind of better organize their in-person visits. They also use it to reduce inefficiencies in a nursing day. They're definitely using it to reduce those readmissions. You know, that's really what they're tasked with for seeing these patients. Increase patient communication and education. They have a really strong patient satisfaction with the program. And so that can also really help them to strengthen their referrals as well. And then in the primary care space. And so this is absolutely applicable to medical groups and community health centers and FQHCs, just using it to really better manage their growing number of patients with chronic disease. Of course, to reduce readmissions, to reduce wasteful spending is really important, to help out with patient compliance. with patient medication adherence, to enhance video telehealth calls. This is a big one as well. So there's no doubt that video telehealth absolutely helps doctors stay connected to their patients. But sometimes that video chat is just not enough. So sometimes, especially for patients with chronic disease, it's so important to get that data. The data is what's missing. So it's things like the blood pressure, or the weight, or the blood oxygen saturation, or if they have diabetes, the blood glucose level. So things like that are so impactful and helpful for those physicians to make decisions on how to move forward with a particular patient to avoid those acute events. And then the last thing I'll say in terms of the primary care space is that there is some reoccurring revenue that has to do with reimbursements. And I know Wanda will talk to you a little bit more about that later on today. And then among the community health centers, finally, we're seeing a lot of really great funds available in studies, and more that are coming as well. Okay, next slide, please. Okay, all right, great. So we talked a little bit about the why remote patient monitoring. So next we're going to talk about the how. And I think this is where a lot of people are and what they kind of get stuck on. They're like, I get it. You know, I know the data is there. I'd like to think about maybe implementing remote patient monitoring in my practice or whatever segment it is. But how do I really do this? Can I do it? You know, what are the rules that are involved? Do I have enough time to do it? Things like that. So I thought I would just kind of walk through kind of step by step some things to consider if you are considering implementing an RPM program. Next slide, please. Thanks. So the first one is just, and this is, I know this is probably something that you would already know, but just defining that need. Really, what problem are you trying to solve? Kind of pinpointing it, narrowing it down. So are you trying to better manage your chronic disease population? Are you trying to improve access to care in those rural settings, or older patients, or those with limited mobility? Are you trying to follow up with patients after they've had a hospitalization, or those with COVID? And it could be none of these things, all of them, one of them. You just want to define really what that need is for your specific organization. And the next slide. Okay, so once you kind of have that need, you have to think about patient selection. And this is a question that I get a lot. Remote patient monitoring can really be used for anybody. So how do I narrow my patient population down when there's so many people that could potentially benefit from this? And so we really, and there are software programs out there and applications that some people have that will tell them these are your patients who are at highest risk. But if you don't have something like that, usually organizations will kind of start with one chronic disease, maybe the one that they're struggling with the most. So maybe it's hypertension, maybe it's diabetes, a COPD. So really kind of picking that one area, and then from there, breaking it down a little bit further. So there can be an inclusion list and an exclusion list. And these are just some examples. But you might want to think about, okay, it's a patient with hypertension who has been in the hospital 1 or 2 times in the last year. Is it somebody who has a poor medication compliance history? Is it someone that you already are asking them to take their blood pressure on a daily basis anyway and let you know if it gets too high or too low? So these are examples of the inclusions that you might want to think about. And then the exclusion. So you have a patient population that you think is appropriate, but if they're physically not able to get up and walk over and step on a scale, or they don't have a caregiver to help them do that, that might not be an appropriate patient. If they have an uncontrolled psychological issues or behavioral problems, if their environment isn't conducive to home monitoring, or if they just refuse, if they say, no, I don't want this in my home, that's probably not a good patient to be on the program. And I will say, and on the next slide, we'll talk about how education is so important for these patients, letting them know, okay, this is a remote patient monitoring program. This has been proven to keep you out of the hospital, and letting them know really the benefits of the program. I think that goes a really long way for the patient to understand that this is something that will help them. But again, if you have a patient or caregiver that just says no, then obviously that's, that wouldn't be an appropriate patient. Okay, next slide, please. All right, so the initiation of care, once you've kind of defined your patient population, you want to think about the initiation of care. So again, the first thing you want to do is educate those patients about the program. And getting a consent from a patient is important. A verbal consent is a definite, but a written consent is up to you. It can, some organizations have the patient sign and say, yes, I'm going to be compliant. I'm going to use the program every day, and I'm going to be responsible for returning equipment when I'm finished. Others don't do that at all. So it's just completely up to you, but just educating the program, the patient about the program is really important, and just getting that consent and documenting it. Then you want to think about the care plan. So how often do you want them to use the remote patient monitoring equipment? How often do you want them to get on the scale or take their blood pressure? We always leave this up to the providers to decide, but when people ask us for our opinion, what we see the most is that patients should use it every day. And there's a few reasons for that. First of all, you're going to get trends that way. So you're going to be able to see when things happen inside the patient's trend. Another reason is it just helps that patient get in the habit of doing something every day. You get up, you have breakfast, or before you have breakfast or whatever it is, same time every day, use the remote patient monitoring devices. And then the next thing to think about are alert thresholds. So a lot of remote patient monitoring programs will allow you or your staff to receive notifications if they have biometrics that have fallen outside of some sort of boundary. So if you have a patient on a blood pressure monitor, you want to know if their systolic or diastolic is too high or too low, or the heart rate is too high or too low. So you can choose to have notifications, or a web portal that you go to will show you a red flag or something like that. So you just kind of want to define those ranges of your notification of when your patient has fallen outside of your boundary. That way you'll get an alert to that, and you won't have to be manually looking through all the data on a daily basis. And then symptom questionnaires is another one. I know some organizations really like to not just monitor their vitals with the devices, but also monitor the patient's symptoms. And so you can do that. A lot of times it's done in the office, where you might have a symptom survey. Maybe it's the COPD assessment test or the Minnesota Heart Failure Questionnaire or something. And they can all do that electronically now through remote patient monitoring programs. So that could be something that you want to decide whether or not your patients want to take any type of these symptom questionnaires. And then you want to think about patient training and setup. So how are you going to train that patient? Are they going to come into the office, and during an office visit, if you talk to them about the program and they decide that they want to be a part of the program, are you going to have a kit right there to show them how to use? Or is it going to be something where maybe you talk about it, but then they go home and you ship a kit to them, or they take it home with them and you have the training over the phone? Or do you have community health nurses in your area that can go out and physically bring the devices to the patient's home and train them in their home? And I've seen it work all three ways. Some organizations do a combination of those. We at Remetric Health offer patient training. We do trainings with patients all the time. We do it all through the phone and through video telehealth. So, you just have to decide what works best for your organization. And then the patients will use their biometrics, and they'll start responding to any of those surveys, those symptom surveys, if you want them to take those. Okay, next slide, please. Okay, thank you. So then you want to decide the next step is actually monitoring that patient data and the management. So is it going to be a medical assistant or an LPN or a nurse or somebody that's at your organization that's going to actually review the patient's data, look at their trends on a web portal or through your EHR, and respond to any of those red flags, those threshold alerts, and kind of triage as necessary. So if you're going to get an alert that their blood pressure is really high and it's out of bounds, maybe you have your nurse call that patient and talk to them, what did you eat for dinner last night? Was it salty or whatever? And just triage as necessary and determine, do I need to tweak meds? Do I need to bring them into the office? Was it a false alarm? That kind of thing. And then obviously you want to document, all of this information in the portal or your EHR. Next slide, please. Okay, thank you. So this is a workflow. This is kind of just summarizing what we've kind of spoken to already. So the first thing you want to do is identify that patient population. And just move this little picture box out of the way. And next thing you want to do is have your administrator or somebody that kind of creates that patient profile within the system, kind of says, okay, this patient's going to be on remote patient monitoring. Patient receives the kit, patient's trains on the kit, then they start using the medical devices. There's somebody that monitors the patient, and then you can decide how long to keep your patient on the program. So it just depends on the segment. In primary care, they may leave a patient on the program indefinitely. They might leave them on for years, and that's perfectly okay. In home health or the hospital space, they might only leave the patient on for 30, 60, 90 days, kind of get them past that readmission penalty. And then after the patient no longer needs to be on the program, they get the kits back, they wipe them down, and now they reuse them on the next patient in need. You can absolutely do that as well. So it just depends on the length of time that you think is appropriate for your patient population. And then the cycle starts over again. Okay, next slide, please. Okay, great, thank you. All right, so I just wanted to go over a couple considerations if you do decide to move forward with RPM in terms of vendor selection. What I will say is that, so we've been doing this now for over 11 years. And I see remote patient monitoring companies pop up almost every single day since COVID, and even since back in 2020 when the reimbursements became really strong for remote patient monitoring. So there's a lot to choose from. There's a lot of things to sort out. It just depends on the needs of the organization and the population of patients that you serve. So here are just some things to kind of decide and think about if it's important to you or not. The one thing I do think is so important is to have a high quality customer service and support team. You don't want to go, with a vendor that's brand new and is kind of learning along with you. You want somebody who's been doing this for a while and can set you up and show you how to run the program. Some of them even provide clinical teams, so they have their own staff of nurses that can actually do the patient training or even do the patient monitoring and triaging for you. But inevitably, there's going to be a question with any new program that you're starting, and this has to do with some technology. You're going to have questions. There's going to be new people brought on that need to be trained. So you want to have a company that offers that and provides that ongoing support to you. The next thing that's really important to think about are connectivity options. So there's no one connectivity that's right for every single patient. So you want to think about things like Bluetooth, cellular versus Wi-Fi versus mobile apps, because you're going to have patients that have smartphones and they're perfectly capable of going to the app store and downloading an app, and their devices hook right up to it, and it's easy, and that's great. But then you're going to have patients who live in an area where they don't have a smartphone or a cell phone. They don't have internet connection at their house. They don't have like a modem at home with their own Wi-Fi. So you're going to have patients that need some sort of cellular data as well. So cellular data is much more expensive than just a mobile app. So you want, and you don't want to use that for everybody if you don't have to. So you want to be able to have multiple different options for when you need them available. You also want to make sure that you go with a company who has multiple devices or a number of devices that you think eventually in the future you may need. I know right now in community health centers, as an example, there's been some wonderful funding for hypertensive studies. And everybody in that space is in need of a blood pressure monitor for remote patient monitoring. But down the road, there may be another study where you need a pulse oximeter or scale or something like that. And you don't want to have to go to like 3 different vendors for your remote patient monitoring. You want to be able to go with somebody where you can add devices on at any time that you need to your existing program. And also, it's so important to make sure these are easy to use devices and programs for your patients as well as your staff. And then some features to consider. EHR, I know a lot of people ask about this. Can you integrate with my EHR? And so even if it's something where you may not be interested in doing an EHR integration right in the beginning of setting up your RPM program, but you think and you hope to grow your RPM program, so eventually one day you've got 500 or some patients on it, at that point, you're probably going to want an integration into your EHR because if you're trying to get all the data from one platform into the next, it's a lot for 500 patients every month to, send that way into the EHR. So an integration is key in that example. So I would just want to check on that as well. Reporting, especially if you're doing billing, the reimbursements for remote patient monitoring, Wanda will talk to you about those, but if you are going to be doing that, the codes say for the CPT codes for remote patient monitoring that you need to have spent a certain amount of time with your patient reviewing the data every month. So you want to make sure you go with a system that's going to automatically document all of that for you and just have that report in one neat little click of a button so that you have that information for billing purposes. Also patient engagement and compliance tools. So something as small as even like a little text message or an email sent to a patient or a pop-up on their tablet or phone that says, hey, it's time to use your blood pressure monitor today is really important, and it can go a long way with those patients to help out with compliance. Video telehealth. So everybody's using video telehealth right now. However, when you have an RPM program and you see that there's an alert of some sort and you want to reach out to that patient, video telehealth within that actual remote patient monitoring system can be really helpful so that you don't have to jump out of that into something else to make a video call. And again, these are all just optional things to think about. The questionnaires for their symptoms, that's another thing that might be important to you. And then you want to think about, in terms of the company itself, somebody who's affordable, because everything can make sense clinically and everything can make sense in terms of it being an easy to use program. And yes, I think I can implement this, but if it's really expensive, it's just not feasible. So you want to make sure it's, well priced. And then also I would say, make sure the company is at least FDA registered. I think that is really important. And a lot of these RPM companies that are popping up are like health IT companies that are kind of trying to get into the buzz of it. And you just want to watch out, at least make sure they're registered with the FDA. Okay, next slide, my last slide. Overcoming challenges, because with any new program, there are going to be challenges. And these are just some of the big ones that we see the most often. And then what is the way forward? So I hear a lot, limited staff and time to monitor patients. Everybody's so busy already. Can they really start up a whole new program? And so for this, I would say definitely, again, finding an experienced partner, somebody that can help you do it right. Not somebody that's just going to sell you some devices and then you're never going to hear from again. Somebody that really wants you to succeed and kind of be in this partnership together. And also some of them do offer clinical services if you wanted to kind of outsource the entire RPM program. Lack of internet connectivity. Again, we kind of talked about finding out which option is right for your patient population, making sure there's a couple different options, or at least the option that you think is most applicable to your patients. There's always going to be dead zones, no matter which cellular network is out there. I do think the best is Verizon Wireless when it comes to cellular data, because just in terms of connectivity and speed, but inevitably there's going to be a dead zone somewhere that the cellular service just isn't there in the US yet. And so in that case, what you can do is make sure that the devices that you use hold on to that data. So that way, if the patient uses it and then later on that night walks to another area in their house and it picks up cellular service, or maybe a week later, they walk out down the street to, a nearby McDonald's or something, that all of a sudden the internet connection picks up, it automatically sends that data. You don't lose that data. So that's really important too. Patient compliance. People worry my patients aren't going to use this. Again, education is key for these patients. Not everybody's going to just start and use it, and you're not going to have to make a phone call in the beginning, that first week or two to really get them on board and remind them to use the program. It does take that for some patients in the beginning, but then once you get past that week or two and they get in the habit of using it, that's where things get a lot easier. But sometimes that initial, training and just reminding them to use it, it is there. But overall, you will make sure that as long as you kind of follow those inclusion exclusion lists and you're choosing the right people that you've educated, you're going to have a compliant patient population. And then last but not least is lack of reimbursement for federally qualified health centers and community health centers. until recently, I didn't have a way forward for this one. I've talked to federally qualified health centers for years about remote patient monitoring. And it was always the same thing. They were interested, they wanted to know about it, how it can help their patients. But at the end of the day, when they learned there wasn't any reimbursements for Medicare at that time, it just took the wind out of their sails. And it was so unfortunate. But now we are finally starting to see really decent federal and state funding for remote patient monitoring. We're starting to see private payers open up, Medicaid opening up a little bit. So things are changing and they're moving in the right direction. So there is, I do believe that there is a way forward among the FQHCs and CHCs as well. And we're seeing it, witnessing it today. Okay, so I will let Wanda take it from here.
Good morning, everybody. How are you doing? Hopefully you're having a good day and enjoying the presentation. I'm going to be talking about the financial side of patient monitoring. This is in forefront, every practice and facilities question is, what does that reimbursement look like? What is the ROI? So we're going to move forward. Next slide with that. Okay, let's talk a little bit about remote patient monitoring and the codes that Medicare requires for primary care. Thing to remember is to reduce the likelihood of denials, you want to make sure that you're compliant with all CMS guidelines and being very proactive in monitoring and auditing your information's coming in and your charts. The CPT's 99453 is for the device setup. On that one, the national average is $19 one time per patient, making sure that we're only doing that once. CPT 99454 is to supply the device for the programmed alert transmission, and that would go monthly per patient. You want to make sure that you're using those conjunctively correctly. That can lead you with denials right away. The 99457 is, as Rebecca had spoke earlier, is time monitoring, so 20 minutes of data interpretation there per month per patient, and for visit, and you have to have 16 days of monitoring. That's very important for correct billing. If you fall short of that, you will get denials on your claims if you're not meeting that minimum threshold of 16 days per month being monitored. CPT 99458 is an additional 20 minutes of data interpretation, $33 facility national average, and $42 non-facility national average per month, monthly per patient. We want to make sure that we're using those conjunctively and in the appropriate setting. That's one of the things that we look for when we're looking at the billing on your claims. The problem that you have is when you don't have somebody experienced with using the 99453 or the 99454, you will run into issues with getting your claims paid. Also, monitoring your contracts with your Medicare and Medicaid Advantage plans, making sure that there's not an exclusion for monitoring in those. The 99091 is a one-time 30-day, which isn't used as much anymore. It's 30 minutes of data analysis for billing physicians and cannot be billed concurrently with 99457 or 99458. Okay, next slide. Let's talk about a little bit more of the patient monitoring eligibility requirements. An established patient-physician's relationship is required for RPM. During this, you can, during the pandemic, they can be waived, and that will soon, we'll know if that is going to continue or if that'll be changed once the pandemic is over. Going to the consents, it's advised that you try to get a consent. It is advisable that we have a consent on file. It's not always needed, but it's highly recommended for if you do have a denied claim. We do have consent from the patient. CPTs 99453 and 9954. is the patient's education and setup and supply of the device. Your clinical staff, as well as the auxiliary personnel, can be the one monitoring this, but you need to make sure that it's billed under the physician or the NP of the practice. CPT 99457 and 99458, monitoring and evaluation, is again the same. You want to make sure that it's being monitored and that it's being billed correctly. You want to make sure that the time spent that we spoke about on the previous slide, the 20 minutes, that we're making sure we're monitoring those very well. And technology, back to Rebecca's point earlier, was technology use must be defined and as a medical device approved by the FDA. 16 days of monitoring. I can't stress that enough. You must have 16 days to get your claims paid of every 30 days to meet the requirements of the 99453 and the 9954. I find that to be the most denials that you'll receive if somebody's not monitoring those on patients' claims, that you will come up with the most denied reasons for not having those minimum days met. RPM services must be medically necessary for patients with chronic conditions as well as patients with acute conditions. The 20 minutes of time required to build the services of CPTs 99457 and 99458. Include the time for furnishing care management services and monitoring the patients and interactive communications. The codes that require general supervision by an MD and NP, the codes are for Part B services and are billed on a 1500. I have had facilities that's made that mistake in billing it on a UB. It does need to be on a 1500 form using the NPI number of the supervising qualified physician or NP. And the RPM codes are subject to the 20% beneficiary copays. And again, the physicians can choose to waive during the pandemic. They do have a slated date for that to end, but who knows if they continue it, then we may be able to continue to offer that as an option for our patients. Next slide. Recurring revenue for providers. So CPT 99453 setup, $19. Initial setup and patient training on the use of the equipment. Very important to make sure they understand so that they can get the true benefits of the monitoring and they understand the benefits of it. CPT 99454, device use. Report the code for each 20 minutes of monitoring each month. Make sure that that is being done, that you are having a way to track that is very important. CPT 99457 monitoring, $51 and 99458 is $42. Report this code for additional second and third 20 minutes of monitoring each month. Again, tracking this can be useful for, claiming, appealing in a claim if you should get a denial. And a total of 156 every 30 days. Remote patient monitoring program can yield $1,300 plus per patient per year in net revenue. Okay, next slide. Okay, this is an example of an RI for 100 patients. If your facility or office had 100 patients using these same CPTs that we discussed earlier, over this would be a positive net revenue of on 100 patients of $123,000. Again, this reimbursement is for financial information provided, is meant for directional and not legal financial advice. Please consult your local teams, financial teams for your region, and look at your contracts and make sure that your contracts do not have any exclusion written into them. That's very important. Okay. So upon our thing for Indiana Medicaid coverage for home health agencies, the requirements are as follows. Members must be receiving or approved for an IHCP, home health service. Members with COPD and CHF or diabetes. And the members also initially have 2 or more emergency room visits or hospital stays related to one of the conditions within the previous 12 months. Members must provide consent, again, RPM requires prior authorization. Registered nurse perform the rating of the information. So it doesn't have to be the provider himself or herself. It can be your nurse there on there, as long as the claim is being billed under the provider. Must have a written order or a care plan from the physician, and must be authorized up to 60 days. Home health agencies bill telehealth services using a revenue code of 780 along with CPT code 99600 with the appropriate modifiers. And down below, we have listed a few of those modifiers that you would list. Unlisted home visit, that would be a U1. And then unlisted home visit service procedure to a remote skilled nursing visit would be a U2 and a TD with RN reading. And then at the bottom, you can see that we do have a link there for you to follow as well. Okay. And we just listed a few of our resources on this page. The Remote Patient Monitoring Toolkit for Telehealth Resource Center is a very excellent source. Always CMS is COVID-19 frequently asked questions. I refer to that a lot. And Billing for Telehealth Encounters is another excellent source. And then of course, for your area, it would be Indiana Health Coverage Program for Telehealth Services. And those will be provided for you as well at the end. Thank you.
Well, ladies, thank you so much. Catherine, did you have anything you wanted to add?
No, I was just going to say, I'll turn it back over to you to see if there were any questions that we can answer for anyone.
Absolutely. The one question that I saw, Rebecca answered in her comments. So now is the time to submit your questions through the Q&A. And while you are doing that, I'm going to also ask Carolyn Miller to go ahead and put the link to our survey. It's a very short survey. If you would go ahead and put that link into the chat, and please avail yourselves of the opportunity to provide some feedback to us. So at this time, I'm not seeing any questions in the Q&A, but I do want to thank you. Such a wealth of knowledge from the different perspectives. And I've been a fan of remote patient monitoring programs for a long time. I'm glad that they're becoming more popular because I think they have so much value for them with patients that might be struggling with, different chronic care conditions, and just watching patients with certain diseases on a regular basis. All right. Any other questions? Got a quiet group today.
It's a Monday.
Here's one. How do non-provider clinicians bill under the Incident 2 with supervising providers? Who wants to take that one?
So I can just ask a quick question. Non-provider clinicians bill under Incident 2. So with remote patient monitoring, you do have to be, for billing purposes, to actually bill the codes, you have to be an MD, NP, or PA. However, the person actually doing the monitoring does not have to be that. It just has to be overseen by a physician or an NP, PA. So the person doing the monitoring, the day-to-day, looking at the patient data and such, that can be an LPN, a medical assistant. So you just do the monitoring, the time is all recorded, and then the provider would bill for it. And obviously you would go to the provider if you need to address any patient care, medication changes, those types of things.
Okay, so only the supervising provider is the one that bills.
To actually do the billing, yeah.
Yeah, okay. Thank you. Good clarification. Any other questions? All right. Well, if you would, as we're finishing up, go ahead and take that survey. The link is in our chat. We did have a question come through on the Q&A. Oh, so what happens when a patient returns the kit? Are there any specific recommendations for cleaning or disinfecting the devices?
I can take that. So that's a great question. It definitely is determined by the vendor that you purchase your equipment from. I can speak to ours as an example. You want to wipe it down with a disinfectant wipe. If you keep it wet for at least, I think it's 10 minutes, then it's considered fully disinfected, and then you can use it on the next patient. You can go onto the web portal to reset it so that it's not going to show any previous patient data. So it's a pretty simple process. To get those devices back, it just depends on how you're administrating the devices. So for home health, as an example, the last time the nurse sees that patient, she'll pick it up and take it back. Or it might be somebody in the primary care space that's returning to the clinic, getting checked out for their yearly checkup. And, at that point, you can get the kit back. And then in other cases, you can have them ship the kit back. So those are just some of the ways. But again, just disinfectant with a bleach wipe, and you're good to go.
Great, thank you.
Sure.
All right, well, I'm not seeing any other questions, so I want to thank you all for your time today. And there's several thank yous and nice jobs in the chat. So
Thank you.
we appreciate all of your time today and your knowledge and sharing this with us.
Thank you so much for inviting us.
Yes, thank you.
All right, everyone have a great day.
Have a great week.
Bye.